my favorite subjects that I have been going around all these years working on it. And just to tell you about the diabetes and hypertension, we increasingly recognize as we see a lot of diabetes patients in our OPD. 5 years ago, I used to tell people that almost 30 to 40% of diabetic patients have hypertension. Within 5 years, my concepts have changed, and as we see more and more diabetic patients, we find that almost 60% of these patients have hypertension. Increasing awareness about the taking of blood pressure in diabetic patients is very, very important. Cardiovascular events are more prevalent in hypertensive diabetics than in normotensive diabetics. This is very well known. Microalbuminuria, more prevalently in hypertensives, that is 24% versus 14% in normotensives. The risk of developing diabetic nephropathy is 10 to 20-fold greater than in patients with type 2 diabetes who do not have microalbuminuria. It has been considered that microalbuminuria detection is considered as good as having a cardiovascular disease or having a retinopathy. The coexistence of diabetes and hypertension leads to increased cardiovascular morbidity and mortality. The process of type 2 diabetes in India is increasing at a very fast pace, and this is likely to also contribute to a significant burden of hypertension. 30 to 35%, this is what was my concept. Similarly, the incidence of hypertension is 1.5 to 2 times greater in patients with diabetes mellitus as compared to non-diabetics. What is so great about the Indian hypertensives? Why do we have diabetics having hypertension? The Indian hypertensives, they are centrally obese, so increased insulin resistance. Young people have hypertension, as I already alluded to in my earlier lecture. There is increased insulin resistance in centrally obesity, and combination therapy of hypertension is recommended early in diabetic hypertensives. This is the pathophysiology of insulin resistant and hypertension, how it causes primary, secondary insulin resistance, and the primary CNS drive also causing insulin resistance. This is a very important statement regarding the management of hypertension in diabetes. UKPDS, a very, very important trial, a mega trial, which opened the eyes of controlling blood sugar. And the very important observation made that time, 15, 20 years ago, is that blood pressure reduction itself may be more important than the two types of drug, that is the ACE inhibitors or beta blockers. I think Dr. Venkatram alluded to this yesterday, that don't give a misconception that by this Wikipedia statement that control of blood sugar is not important. But what is important is a statement that blood pressure reduction itself may be more important than the two types of drugs that are, that time the ACE inhibitors and beta blockers were being used increasingly at that time. But now we have other drugs used to achieve it. Health economic analysis showed that tight blood pressure control is cost effective when compared with other widely used preventive strategies and is more feasible for most clinicians and patients than tight blood glucose control. A very important statement made in the UKPDS. And the ADA position in 2002, A-level evidence shows that patients with diabetes should be treated to a diastolic blood pressure of 80 millimeters of mercury. And the ADA statement in 2013 says, at that time they said systolic 130, but now they have said that the blood pressure, target blood pressure should be 140/80. And that has been also alluded to in the Indian guidelines on hypertension. Initial drug therapy may be with ACE inhibitors or ARBs, beta blockers or diuretics. Additional drugs may be chosen from these classes or another drug class. This we will discuss In patients with diabetes, blood pressure targets should be less than 140 by 80 millimeters of mercury as per the recent ADA guidelines brought out in 2013. This is from the guidelines again, is that blood pressure should be measured on each visit of the diabetic patient and the procedure for, because in diabetologists they only think in terms of controlling blood sugar. But this has been very, very emphatically recommended that blood pressure should be measured on each visit of the diabetic patient and the procedure for measurement is the same as in ordinary hypertensive patient. Yesterday we learned about the measurement of blood pressure by Dr. Guha, very nice lecture. In diabetic population, it is imperative to measure the blood pressure in supine, sitting and standing position to exclude the possibility of autonomic neuropathy and postural hypotension. Management of hypertension, I'll straight go into this, is all the guidelines mention this, whether it is Indian, European, NICE guidelines or JNC guidelines or Indian guidelines on hypertension, they all say that non-drug treatment should not be forgotten in the management of hypertension. Some of the earlier trials like UKPDS and HOT showed evidence in favor of treating high normal blood pressure aggressively, but subsequently in the ESH-ESC guidelines 2007, no definitive data was available to substantiate this. It is recommended in the guidelines that high normal blood pressure, we have done away with the terminology of pre-hypertension. Even in the guidelines, second guidelines, we have never mentioned about pre-hypertension. There were reasons for that. Because if you talk of pre-hypertension, in the lifespan of an individual, if you talk of pre-hypertension, 50% are never going to get hypertension. Treatment of pre-hypertension is going to be lifestyle modifications. If you label a person as pre-hypertension, he'll only think of hypertension and not pre-hypertension. That is always thought of even by the physicians. They forget that pre-hypertension has not to be treated with medicines. And this is forgotten. As soon as a physician sees a pre-hypertensive, he has an itch to start medications, which is not recommended. And that's why the Indian guidelines on hypertension has done away with the terminology of pre-hypertension and they have coined it as high normal blood pressure. It is recommended that in high normal blood pressure, more aggressive lifestyle measures should be followed, while a blood pressure of more than 140/90 millimeters of mercury should be treated with pharmacotherapy to achieve cardiovascular and microvascular protection. I will not go into the details of this. We have discussed it at length yesterday, the lifestyle modification and the non-drug treatment approach, which remains the mainstay of treatment from the day one of diagnosis of hypertension till lifetime, I believe. In the management of diabetic hypertension, this is from Indian guidelines, lifestyle modification has to be more than aggressive. Lifestyle measures include weight loss in case of obese, dietary changes like low salt and low fat, regular exercise form the basis and are applicable at all stages of hypertension. It has been proven that it is useful and effective to treat hypertension in people above the age of 65 years. Ideal antihypertensive drug, one which reduces the blood pressure effectively, neutralizes the glycemic effect, reduces insulin resistance, neutral lipid effect, uric acid, reduces or does not have effect on uric acid and does not have the effect on the lifestyle of individual, that is, does not cause impotence. These are all the drugs which are available. You are all aware of it. I will not go into details. Diuretic, ACE inhibitors, beta blockers, ARBs, alpha blockers, centrally acting drugs, calcium blockers, renin inhibitors, vasodilators. We are talking of combining all these drugs. And in certain resistant hypertension, you might have to use the not so conventional drugs in combining them to achieve the target blood pressure. It has been observed that to effectively lower the blood pressure, a combination of two or more drugs are required for controlling the blood pressure to target levels in a diabetic population. ACE inhibitors in the HOPE trial and ARBs in the on-target trial have emphasized the importance of RAS blockade to reduce the risk of complications of diabetes, especially both micro and macrovascular complications. Therefore, ACE inhibitors are recommended as the first-line drug therapy, while ARBs may be used in patients who are intolerant to ACE inhibitors. CCBs have been shown to be useful as monotherapy and in combination with ACE inhibitors in the ESCOT trial. The combination of amlodipine and perindopril, this was discussed at length yesterday, was associated with significantly less incidence of new onset diabetes as compared to the combination of beta blockers and diuretics. Beta blockers potentially mask hypoglycemic symptoms. Beta blockers are falling into disrepute in an ordinary hypertensive patient, but in diabetic population with evidence of coronary artery disease and congestive heart failure, they may be quite useful. This was also at length discussed yesterday, but I'm sure Dr. Amresan will talk about this in his lecture, and Dr. Ukol and Dr. Venkatram. It is recommended that we may use cardiovascular selective beta blockers like nebivolol and carvedilol. Alpha blockers can also be used as a useful adjunct in the treatment of the above clinical scenario. The ACCORD trial in diabetic hypertension has shown benefits of effective BP control in diabetic patients. It was observed that to prevent one stroke, this is very, very important observation, it requires to treat 89 patients with intensive therapy of blood pressure control for a period of 5 years. But that intensive treatment is very important because you know what stroke entails. No one wants to have a stroke. And in hypertension, especially with a comorbid condition, diabetic, one has to be very, very careful. And it is recommended that we do bring down the blood pressure to a target level. The ADVANCE and the INVEST trial shows definitive improvement in the macrovascular complications, especially in kidneys, but their effect on eye and neuron complications is questionable. The therapy and the targets need to be individualized for each patient depending on age, young or old, comorbid conditions like kidney disease, heart disease, stroke, retinopathy, all this, and peripheral neuropathy has to be considered in choosing a drug. Cost factor, this is going to be a lifelong disease. As I said, some patients take treatment 1, 2, 3 months, 1 year and then stop it. It's a lifelong treatment and cost factor do come in, and the socio and psychological factors also is very important, and also health condition, importance, whether it creates importance or not, also has to be considered. The use of ACE inhibitors and ARBs is contraindicated in certain situations. Use of diuretics during pregnancy can lead to reduction of plasma volume, which can result in low perfusion, resulting in decreased fetal growth and fetal damage. This has been recognized in the guidelines also in management of hypertension in diabetes. So ACE inhibitors, ARBs, we all know, we don't use in pregnancy, but also a mention about the diuretics. These are the various trials. I think yesterday this has been discussed, and the compelling indications and the recommended drug, we all know about this, diabetic, chronic kidneys and stroke prevention. Thus, to conclude, most patients with hypertension will require 2 or more antihypertensive medications to achieve goal blood pressure. In diabetics, BP should be lowered to as low as can be achieved without side effects. Yesterday we were discussing about patients having hypotension symptoms even when you reach the levels of blood pressure of 130/80. So that is what is important. is that blood pressure should be lowered to as much as the patient can tolerate. You should not make him flat by controlling his hypertension. So he has to be active, he has to be mobile. So even if you can reach 130 by 80, or in patients who can tolerate even 110/70, is welcome in patients with diabetes and hypertension if you can tolerate that blood pressure. The most effective therapy prescribed by the most careful clinician will control hypertension only if patients are motivated. This is very, very important. Motivation improves when patients have positive experience with and trust in his clinicians. And the trust and the motivation will only increase if you have a frequent follow-up with these patients. Because every follow-up will clear a few questions that are there in the minds of the patients. Empathy builds trust and is a potent motivator. Thank you.
Thank you, Dr. Siddharth, for two excellent deliberations please, so we have to come out with our Indian guidelines. JNC 7 has not yet come out even after 10 years for JNC 8. And I mean, after JNC 7, it came in 2003. And even after 10 years, we are not out with a newer guidelines. So we have got such a huge populations, we should have our own guidelines in our setup. I think you've got a lot of questions for you.
Can I ask a question?
Yes.
Can we use the ACE inhibitors in non-hypertensive diabetics, type 2 diabetics?
Well, this has been a debate, and I think Dr. Especially this question has come up with patients who are normotensives and use of ACE, especially for kidney protection. And I think this will be taken up in the next lecture. But it is recommended, especially patients having microalbuminuria. ACE inhibitors are recommended in normotensive patients if they have any comorbid conditions. But personally, I would not like to use ACE inhibitors in a normotensive individual if he has no comorbid conditions. But if there is a comorbid conditions, normotensive with even a marginal amount of microalbuminuria, we must use ACE inhibitors.
It has been rationalized that some of these long-standing type 2 diabetics who are not hypertensive, their intrarenal glomerular arterial hypertension is more. And this is the one which is, if it is reduced, they may be protected. Kidney protection may be there.
That's what I said, that comorbid conditions, consider the comorbidity. Diabetes is a comorbid condition, and we have to take a call in using the ACE inhibitors. After all, ACE inhibitors are not absolutely safe.
Sir, in one of your slides, you said that ACE inhibitors should be the first line of drug, and if
Yes.
it is not tolerated, probably the ARBs.
Yes.
But yesterday, in one of our discussion, Dr. Hiremat had a viewpoint that ACE inhibitors are a best drug if a patient has a hypertension with ACS. Otherwise, probably ARBs are if a simple, plain, uncomplicated hypertension patient, what will be the first choice, ACE inhibitor or ARBs?
Okay, I think this debate will always go on, but in the meta-analysis of the trials that have been done up till now, it has been mentioned, and this also guidelines has also said the same thing, that ACE inhibitors is the first drug of choice. There is very little difference between the ACE inhibitors and ARBs. I am giving a very statement which is very, very controversial, but that has been put in the guidelines, that ACE inhibitors and ARBs, there is very little difference, and there are some pleiotropic effects in the ARBs which prompt us to start with ARBs. But remember the cost factor, as I told you. The guidelines does mention about the cost factor and the lifestyle. So ACE inhibitors are definitely considered as the first line of therapy.
But sir, let us all admit it very clearly that ACE inhibitors nowadays are not being prescribed by the physician as the first line of treatment.
No, that's not true. That's not
Just a minute, sir. If it is a plain, simple, uncomplicated hypertension.
ACE inhibitors are the first drug of choice, according to me,
all
in
of us will
diabetes.
agree that the ARBs have become the first drug of choice. Plain, simple, uncomplicated hypertension in young.
As far as the guidelines are concerned, ACE inhibitors and ARBs, as of now, are clubbed together.
I think
Hello?
it is an excellent. excellent coverage of the whole guidelines. But then I got one particular point.
Yes, sir.
That as the diabetologist, you call impaired fasting glucose if the fasting blood sugar is more than 100. Then also you got a impaired glucose tolerance. What is the harm if it is more than 120 by 80? You call it as a pre-hypertension. Why do you want to call it as a high normal? Because there are many articles who have said the pre-hypertension has got similar complications to hypertension because there is an existing endothelial dysfunction in the very beginning itself, exactly like IGT and IFG.
Yeah, but that's what we are trying to say. We are not saying pre-diabetes. We are saying IFG and IGT. So we are not saying pre-diabetes. So that is a big debate over the world. And there are conferences for pre-diabetes also. And this is what the core committee decided, that you are labeling someone as a pre-hypertension without, and of these 50% are not going to be hypertensive in their life, in the whole lifespan. So why label someone? That is the debate that we had. Core committee members unanimously agreed that we should not call it pre-hypertension, call them as high normal.
Hello.
ADA
The
guidelines.
latest Brown word has say, you said about the pregnancy diuretics should not be given. They say they have conducted a trial of 5,600 pre-eclamptic patients of diabetes. Given the diuretics, they don't find any of the changes in the fetal and the outcome was good, those who have not received the diabetes. This
No,
is the
sir.
latest Brown word report.
No, sir. We don't agree on this issue because diuretics are really
Brown
not
word,
used, they
they
are
say
not
it's a
recommended.
hypertension written in the Brown word latest, that is 5,600 pre-eclamptic with
Agreed.
pregnancy, they have received diabetes.
But that statement will change. Diuretics are not recommended in pregnancy with hypertension.
So
Even
I have two questions, one regarding lifestyle management and one again about diuretics. So in our Hindu culture, when we go to a temple, we keep our shoes outside and then go and pray to God. And most of the time we worry about the
shoes rather than
shoes,
the God.
whether they are there or whether they are gone from outside. So lifestyle modification is something like that because once you advise lifestyle modification, you know how difficult it is to follow. Almost 30% of our current patients straight away dismiss, saying that it's not possible. 30% of them try to follow, initiate, and after a month or 2 or 3 months, they stop it. And 30% of it continue for a few years. They never continue it throughout their lifetime. So I think considering all these things, recommending just lifestyle management and talking about lifestyle management is like praying for some good things to happen.
Okay, I'll answer that first. Is that lifestyle modification, as has been said in the guidelines, shall remain throughout his treatment of hypertension. If you forget that, imagine if you forget that, you'll have to step up the dose of your antihypertensive agent, what is important. And that is why I said that follow-up of these patients is very, very important. Every time you follow up, something will come up as far as lifestyle. Patients are going, I'll give you a simple example in diabetics, that you recommend diet to every patient, and the first question, after my dietitian talks about the diet for half an hour with the patient, then the patient comes to me, I solve the problems of what has been discussed with the dietitian also with the patient, and then when the patient is getting up, the first thing that I ask them, you understood about the diet, no? What fruits not to be taken? So what is the first question that they will ask you in spite of 15 or 16 follow-ups? Can I have apple? Is it not your experience? Instead of telling them that these are the fruits you are supposed to take and this you are not supposed to take. Every time the same questions will come to you, can I have apple? So similarly, so whenever you are discussing with the patients, same thing will come in hypertension. Can I have little salt? Can I have pickles? Can I have papad? Please give me this. So this is going to be and if you don't tell them, imagine that the blood pressure, if you have reached 140 by 90, a little more control on salt and little exercise without increasing your medications can bring down the blood pressure to the target level. What would you prefer? And that is why on the guidelines we always mention, guidelines are just to give you an information. How you take it, it is for you to decide. But this is what we try to inculcate, and that is why the need of the guidelines. That's why our thinking has changed over the last 5 years. From guidelines 2 to guidelines 3, we have changed our thinking. And that's why we have recommended the diet.
Dr. Gua.
Yes.
Dr. Gua.
I hope I'm not exceeding the time. Yeah, but I think. Dr. Guha. Yes, yes. Give him the mic, give him the mic.
Two issues I want to raise. Number one, regarding the issue of AC-inhibitor ARB. So far, cardiovascular protection is concerned, ACE inhibitor scores over ARB. Because the meta-analysis has showed that the ARBs are at best neutral on cardiovascular protection, while the ACE inhibitors are certainly beneficial. That is number one. But to respond to that question, why ARBs are being used as a first line, that is mostly for the side effects profile. It is almost neutral on that ground. Patient don't come back with cough or other symptoms. That's why we are giving ARBs. Although the evidence-wise, perhaps ACE inhibitors should be given. That is number one. Secondly,
I think that point has to be noted. We are saying this, we are in the same tune. The AC, where it is not tolerated, yes, I would
ARBs
definitely.
are definite alternatives, but the first
Correct.
drug should be an ACE inhibitor. Right. Secondly, you mentioned in diabetic hypertensives that lower the better, to the tune of even 110/70 if that is tolerated by the patient. But in the INVEST trial, there was an increased incidence of sudden cardiac deaths in these patients. So perhaps one should be cautious lowering it to that level of 110 or below.
No, I think in diabetic hypertensive, it is as low as possible for a increased renal perfusion. Dr. Amresan will talk about it, but I feel, and this is what the core committee also decided, that lower the better. But the patient should be able to tolerate that. I think we can discuss this at the when we are going to have the encyclopedia, or you can, I don't know, the chairman can call.
The newer beta blockers
Last question.
are, till that we were used to say that the newer beta blockers are quite effective in controlling the intra-aortic pressure and in turn to avoid the ischemic heart diseases, as well as the newer beta blockers are one of the best drugs as far as the endothelial dysfunction is concerned. And now suddenly these molecules have been replaced by the ACE inhibitors and ARBs.
No, I talked about the use of beta blockers in a subset of population. It is not being replaced. ACE inhibitors, according to guidelines, ACE inhibitors and ARBs are going to remain. And in future, you will find that as our thinking changes, ACE inhibitors and ARBs are going to be the first line of therapy, or I should say second line after the lifestyle modification.
I just pushed you the last question to you, sir. We have talked about a lot of beta blockers criticism and particularly atenolol. If a patient comes to you with a history of 15 years of atenolol he is taking and the BP is not under control, the pulse rate is well under control, no side effects, pure hypertension, no other comorbidities, will you stop atenolol or you will continue with that?
Well, as far as the latest data that is available as far as the beta blockers are concerned, there have been reports of adverse effects of atenolol. So if I were given a choice, even if it's well controlled, we would go on to a better molecule. This is my personal opinion. People may differ. And mind you, the use of atenolol in our country is so huge, it is going to be difficult to change. But the core committee decided we do caution the people for the use of atenolol. We do not recommend that you change over. It's up to your judgment. But that is what is recommended. And core committee felt that this should be an initiative. Two initiatives have been taken by the Indian guidelines on hypertension. The one is about the atenolol, and the second is about the mercury manometer. And these are the two initiatives which will definitely attract criticism, but we as a core group thought that this should be our focus for the future.
Thank you. Thanks a lot, sir.